Assalamu alaikum, good afternoon. My name is Hussein Raif. I'm a consultant endocrinologist at King Faisal Specialist Hospital Research Center, Riyadh, where we take care of a lot of patients with thyroid cancer. Actually, we are a major center for thyroid cancer in the kingdom. King Faisal has been like this for a long time, so we have accumulated thousands of cases. We see about 250 new cases every year, and you can guess probably these are the more difficult ones than the easy one. But I'm very happy to chair and moderate and interact with you in this session with the experience we have. The session we prepared with the help of Dr. Tooley. He's our nuclear medicine specialist at King Faisal, and Dr. Hussein Saudi from the Department of Oncology. Hussein's involvement is recent with us because normally we take care of our patient with thyroid cancer, but the beginning era of using of TKI in those patients has forced us to put hands with our oncologists. They are very busy with other type of cancers. Sometimes they don't consider thyroid cancer as a real cancer, but so we had to take a privilege. We have, as endocrinologists, we have privilege to use TKI at King Faisal. This is unusual, even in the US, but we had to do this because we had to fill this vacuum. We discovered Dr. Hussein Saudi as somebody who's very interested in TKIs, very knowledgeable. So we start some kind of cooperation with him that we hope to continue. So we have, today we prepare a kind of a small session, but we were warned that we have to finish before 4 o'clock, otherwise you're not gonna have lunch. So we'll get you in the restaurant before 4, hopefully 10 minutes before, and then once they close the door, we have all the time to finish the lunch. I will start with some review just of the issue of thyroid cancer, and this will be followed by Dr. Hussein Saudi with some very short overview of the use of TKI in thyroid cancer, something quite new actually, and many of us have not even started to use. Then we will end with 2 interactive cases. They are a little bit kind of complex cases, but this is what we see in our practice at King Faisal, and we hope that you with Dr. Tooley help with nuclear medicine and Dr. Saudi with the TKI issue and oncological issue that you will find them very helpful. But let me ask you one question before we start. How many of you take care of thyroid cancer? Okay, so about 30, 40%, maybe 50%. Okay, this is great because, you know, at least some of you will have the experience to share with us as well. Okay. So we'll start with the case. I think I'm going to go quite quickly in my presentation because we will focus more on the cases later on. But I just, this is an average case to tell you what is the journey of our patient starting from diagnosis till management and then follow-up. We follow those patients for years and years and years after even remission. A 29-year-old presented with history of 4 years neck mass. This is not unusual in our patients. Actually, in a study we did, the average waiting time for the patient to seek help from the time they notice the mass is about 3.5 years. And maybe this explains the kind of little advanced cases we see, at least local infiltration and local disease. Although we know that in some type of thyroid cancer, the cancer doesn't change in years. But there are some more aggressive types that can progress a little more or a little quicker. So in this patient, finally she came because she felt a little bit of intermittent dysphagia, and sometimes it's not a real local compression other than the patient noticing that the lump is getting bigger, so they're becoming too sensitive to this issue. There is a family history of PTC. Until recently, we didn't think PTC or thyroid cancer is a familial issue. But now we have studies that showed actually that there is a trend in the family, and if there's somebody in the family who had thyroid cancer, that increased the risk of others. That's some new information there. So this person had a mass of 5 centimeters. Her laboratory are normal, which is usually the case. And most of us will go to ultrasound at that point to confirm, and to see, not only to confirm the mass because it's easily palpable, but to see if there's any lymph node involvement. So that's what happened. And here I'm just mentioning some of the risk factors. Of course, family history now is considered a risk factor. We didn't do this for years, but recently we're learning more about the importance. Radiation exposure, as you know, is a risk factor for thyroid cancer, but we don't see this here. The Chernobyl disaster, as you know, that raised the knowledge about thyroid cancer coming years after radiation exposure. So normally the ultrasound is done, and the ultrasound features are important for us endocrinologists, although they are not really diagnostic of thyroid cancer. So at the end, you're going to end doing FNA for any thyroid nodule, unless it's a hot nodule. This is where you don't want to do an FNA because they're usually benign. So the features of the ultrasound, we look in the halo, which is a good usually feature. We look for if there's any calcification. We look if there's any interruption, the height versus the width. And these are some of the ultrasound features that might indicate more likely to be benign versus more likely to be or more suspicious. But none of these features are really helpful 100%. So many times we don't depend on this. If you have a nodule more than 1 centimeter, you're going to end with FNA. Nowadays, they do not recommend FNA for nodules less than 1 centimeter, even if they are suspicious, but they recommend follow-up because the value of these small nodules, even if they turn to be thyroid cancer, is not established, and many of them actually does not cause any harm. So the recent guidelines will tell us less than 1 centimeter you follow. If there is suspicion features, if there's suspicious features, you might follow for few years. Otherwise, you do FNA for a nodule more than 1 centimeter. So an FNA, of course, this is the ultrasound features. Maybe it's not something very interesting to this group, but the cytological features, as in this patient, came as suspicious for PTC. Now, fortunately, there is classification for cytology because for years and years it was difficult to understand each other. The cytologists report differently. Now we have a standard report of cytology wherever this report came from should follow these. So they are first the non-diagnostic, where the amount of cells are not enough or so forth. Those are the risk of cancer here is only 1 to 4%, and usually we repeat the FNA. Now, if you get here, which is the benign features that include usually a few cells and enough amount of colloid in the cytology, then the risk is very low, and those are the ones that we do not touch. But we might follow radiologically for the next few years, unless they look extremely benign on ultrasound, like simple cyst, then you do not need to follow. So most of the cases will be here or here, but there are cases, a good number of cases might come as either atypia of undetermined significance, or what we call AUS, or follicular cells, FUS of undetermined significance, or what we call possible follicular neoplasm. Unfortunately, although most of those are benign, we cannot be sure. So the chance of malignancy here comes as high as 30%. So what to do here is a little bit, it's not controversial, but there are different ways of handling things. Some people will repeat the FNA and wash the patient. If the patient is not a very good, as example, candidate for surgery, but you can send your patient for surgery based on this, and this is also quite acceptable. On the other hand, Now here where the cytological molecular markers, specifically BRAF mutation and other mutation that now being described, and maybe Dr. Saudi will allude to this later on, comes handy, because here if you send it and it's negative, then it will decrease the chance of malignancy. Where it's positive, it will increase the chance of malignancy. So we might depend. We have not started this yet at King Faisal, but it's being used in some centers in the world. Of course, if you have suspicious, like in our patient, the chance is 60%, and you might have, clear malignancy where the chance is in the 90%. So those patients clearly will go for surgery. So patient underwent surgery, and normally we go with an algorithm of surgery, radioactive iodine for most patients, but not all the patients, as we will see. Of course, hormonal therapy, meaning thyroxine. And this is usually the end of the story for most of our patients. As you know, the prognosis is extremely good in most patients with differentiated thyroid cancer, and that's probably 80 to 90% of the patient, but then there is this 10 to 20% who might have local recurrence, progression, or might develop very aggressive disease eventually. Not talking about anaplastic, which is extremely aggressive form of thyroid cancer. So very quickly we'll go. The surgical option normally is total thyroidectomy, or near total, where the surgeon might decide just to save a little bit of the posterior capsule so he doesn't cause problems. And of course, if the pre-surgical mapping of the neck doesn't show extensive disease or lymph node involvement, certainly you can go for a little bit less, like near total thyroidectomy. What is the rationale? Why we should do total thyroidectomy when there is a nodule of 2 or 3 centimeters and maybe 1 lymph node or 2 lymph nodes on that side? The reason, of course, that thyroid cancer can be multifocal and bilateral in many, many cases. And also the lymph node involvement is extremely common. How common? If you go by microscopic, then it's 80%. The clinically significant is probably 30%. However, we don't know if you have microscopic disease in a lymph node, that not always means that the disease will come back. So this is why we do near total thyroidectomy in those patients. However, the newer guidelines now tell us that we can do partial thyroidectomy, meaning hemithyroidectomy in some cases. So when the tumor is more than 1 centimeter, we go to total thyroidectomy. This is changing now, and a lot of centers will not do total thyroidectomy unless the tumor is more than 1.5 centimeter. So people is getting a little more conservative in terms of surgery after some studies showing that it doesn't make much difference if you do hemithyroidectomy or subtotal thyroidectomy in certain group of low-risk patients. So why should you subject them to total thyroidectomy? If you have extrathyroidal extension, definitely presence, of course, of lymph node or other metastases, these are all indication for total thyroidectomy. Of course, sometimes you don't know this when you do the first surgery. So some of the surgeons, especially if the nodule is only suspicious or borderline, they might do hemithyroidectomy. Then they go for total thyroidectomy as a second line. But I think if the lesion is suspicious from beginning and is more than 1 or 1.5 centimeter, it's better just to do the total thyroidectomy. Of course, with good imaging before the surgery to see that lymph node. Should you do CT scan or ultrasound? The newer guidelines tell you ultrasound, unless you have lymph node involvement or a complex, you think you have a complex disease, then you go to CT scan because it's better. So, as you said, unilateral lobectomy can be done if the tumor is less than 1 centimeter. Even if after the surgery you find that it was multifocal but less than 5 foci, and there's no indication by ultrasound of a disease on the other side, then you do not need to do completion thyroidectomy. Okay, should we do lymph node dissection on every case? The answer is no. And this usually, if there is suspicion clinically or lymph node, yes, by all means. But if there is no indication of lymph node involvement, then usually the surgeon can do some pickup of lymph node just to be sure, and that will be the end of the case. Central lymph node dissection is done routinely in some centers, but nowadays the newer guidelines does not encourage this on every case. So the low-risk cases should not probably have central lymph node dissection because it's associated with some morbidity, and they save it to tumors more than 4 centimeter or the presence of extrathyroidal extension or already detected lymph node. So this is our patient, and this is how the pathology is being reported. Our pathologist will report the size of the tumor, the presence of lymphovascular invasion, extrathyroidal extension, lymph node involvement. The subtype of the cancer or the thyroid cancer is very important. Sometimes if it's a tall cell variant, if it's trabecular or sclerotic type, then they behave much more aggressively than the regular type like follicular variant or regular BTC. We do staging, and this is how many types of different type of staging there is. I don't know how to do this. We only use the TNM, but some others use different things. And of course, it depends on the size of the tumor, on the lymph node involvement and metastasis. Just to show you the power of risk factors, the age in thyroid cancer. If somebody is under age 45, they are always stage 1, no matter what's the size of tumor or the lymph node involvement, as long as they don't have metastasis. This is because they do extremely well with treatment. So even if they have lymph node and they have large tumor, more than 4 centimeters, they're still stage 1. Stage 2, if there's metastasis. This has changed completely after age 45. So here the prognosis become worse. And here, of course, you have stage 3, and if the tumor is large enough, or we have lymph node involvement, stage 4, if there are metastases or there is very extensive local disease. Usually after surgery, we stratify the risk of our patients. It's very important to us to have initial stratification of risk because that will decide the type of follow-up and treatment they have later. But this risk, as you see now, and as the newer guidelines tell us, that should be modified. So somebody with intermediate or high risk might turn to be moderate risk or low risk later on. So it's not like if somebody is high risk will continue to be high risk. Also, low risk patient might become moderate or high risk patient later on. So there is initial and there's a dynamic type of stratification of risk. And this is generally the low risk patients who have no local or distant metastases. The whole thing was resected, no local invasion, and does not have the aggressive type of tumor like the tall cell or the insular. And there is no uptake in the scan outside the bed, so there's no local or regional, no regional or distant metastasis. Of course, the high risk is when you have clear invasion beyond, not microscopic, but gross tumor invasion that was not resected, the tumor was not resected completely, and you have distant metastasis. Moderate risk is anything in between. Why does it make a difference? If somebody starts with low risk, the chance of recurrence or persistent disease is only 3% over the next 10 years. If somebody started with intermediate, the number goes to 21%, and it's 66% with high risk. Again, the genetics and molecular genetics that's been developing now in the thyroid cancer very rapidly is taking place even in stratification of risk, although we're not using this very often clinically. The BRAF mutation and other mutation usually indicate a worse prognosis for the patient. So radioactive iodine ablation is usually a standard treatment for our patient after surgery. And why we do it: to clean up if there's any micromets, And also it helps us to even clean the normal thyroid tissue that might have left, so the follow-up with thyroglobulin or with the scan will be easier. This was usually the rationale for radioactive iodine ablation. But the more important is there an evidence that it works? Actually, in the very low-risk patient, there is no evidence that it makes any difference because those patients are so good in prognosis. Even if they take or they don't take radioactive iodine, it doesn't make any difference. It is the moderate or high-risk patients that they might benefit from radioactive iodine. So now the newer guidelines restrict radioactive iodine from being given to the low-risk or very low-risk patients. There's no need. In the little bit higher risk, like those who have lymph node involvement and a size of tumor more than 1.5 centimeter, this is a very old study, but an important one, where it showed that if they received radioactive iodine, they will have about 30% less recurrence, and even mortality will be less. So it's improvement in mortality. Of course, not everybody agree with this. There are some centers like Mayo Clinic that always suspected that radioactive iodine doesn't do anything. But this is also a very important study, and this guy who died a few years ago is really one of the big authors in thyroid cancer. So should we ablate all patients? The answer is no. I think I might have a table for this. Who should not be ablated are the ones who have very low risk, which means a cancer less than 1 centimeter, even a multifocality, but they are small, like less than 1 centimeter, what we call microscopic disease, then they don't need to be ablated. What about the others? Okay, I used to have a table here. Okay. So those who have a size between 1 and 4 centimeter, so less than 1 we don't ablate, between 1 and 4 centimeter, if they have other risk factors, extrathyroidal extension, lymph node involvements, then yes, we ablate them. They tell you consider radioactive iodine in this group. More than 4 centimeter, definitely, or metastasis or regional metastasis, definitely they get radioactive iodine. So now we have 3 groups, definite, no, and consider in between. Should we do anything before this? Normally at our center we do the above. The guideline does not tell you to do actually ultrasound post-surgery, but we do it because a lot of those patients who come to us come from outside hospitals, so we don't know whether the surgery was clean enough or not. Should we do a scan pre-treatment? This is different. Some centers don't do any scan, they just give the treatment, and some do. Like us, we used to do scan, and we still do, using I-123. So in this patient, as example, this is pre-treatment. Of course, she was withdrawn from thyroxine. TSH goes up. We measure the thyroglobulin, and in this patient, it was 1.8, which is quite low, indicating that she has reasonable good surgery. But we do usually ultrasound, and in this specific patient, there was a little nodule, hypoechoic nodule, post-surgical. So there's a question whether she has some residual. If it's less than 1 centimeter, or the patient is high risk for another surgery, we may just go to the radioactive iodine and reassess later on. So in this specific patient, her uptake was quite high. Anything above 5% after surgery is considered high uptake. This patient had 10% uptake, so the surgery was not very good, we can say, or she has aggressive disease. Ideally, the uptake will be 1 focus and will be very, very low, like in this person, 0.25%. So this patient, of course, she had her radioactive iodine therapy, and then usually a year later we repeat the scan, although we see them in 6 months to repeat the ultrasound to be sure there's no lesions, or that this lesion that we saw that has disappeared. We use thyroxine not just for replacement, but also as a treatment for thyroid cancer. And should we suppress all patients? That we used to do so, not anymore. The low-risk patient now, we just put them at a low normal TSH. We don't need to suppress them. Intermediate risk, we just mildly suppress them. However, the high risk, we completely suppress their TSH. So we use a little bit higher dose. How do we follow those patients? Normally, we reassess the thyroid function test in a few months to be sure the dose is correct. In 6 months, usually we do an ultrasound, but sometimes if a low risk, we might wait till 12 months. We repeat the scan only one time to be sure that the patient has clean scan, and then we don't repeat thyroid uptake scan anymore. We just follow with ultrasound if the patient is in remission. So finally, let me just show you a table before I finish. The patient then will be re-stratified in terms of risk, depends on their response. And there is something called biochemical response, which is the TG level, the thyroglobulin level, and structural response, meaning is there any disease by ultrasound or any other imaging, we may not know for sure where they have some increase in TG, but we cannot find the disease anywhere. So it depends on this, the risk. If they have excellent response, meaning they have negative scan, low TG, then they have excellent really prognosis, and their clinical outcome is 1 to 4% only recurrence, and mortality is 1%, disease specific. If they have incomplete response only biochemically, meaning TG is still high, but you don't see the disease anywhere, they still do very well, but at least 30% of them will later on come with a disease somewhere. And even when they come with a disease somewhere, you discover the lymph node, they can still be cured after that by further therapy. 20% will develop a real disease that you can find clearly later. Those who have structurally incomplete response, meaning they still have a disease that is seen anatomically, then those do worse, where 50 to 85% will still have persistent disease and require additional therapy. And out of those, some of them do well, so with a second surgery or third surgery or radioactive iodine, but some will become actually refractory to radioactive iodine and might develop metastasis. So this is the group where we need to follow closely. I will stop here, and if you have 1 or 2 questions, then I will ask Dr. Hussein Saoudi to tell us about newer therapies, including TKI, that is taking now or coming to the arena of thyroid cancer.
Thank you, Dr. Hussein, for this excellent lecture, actually. There is some, at the start of your lecture, you said below 1 centimeter we will not investigate. Then in the criteria how to give additional treatment, you put those with more than centimeter at higher risk. So even, I think we will not meet those with low criteria or less than centimeter unless it's incidental discovered during other reasons for surgery.
So we differentiate between nodules. Here you find a nodule on ultrasound. Now ultrasound is done very commonly on patients, and you found this 3 millimeter or 4 millimeter nodule, and what to do with it. So nowadays they tell us just observe, do not FNA such nodule unless it becomes close to 1 centimeter. Some of those might be thyroid cancer, but the chance is small. But even if they are thyroid cancer, they found that they do well for years and years. However, a lot of patients get thyroidectomy for different reasons, because they have a lump. And then incidentally, you see those microscopic cancer of 6 millimeter or 9 millimeter or 1 centimeter. So you have to deal with them as such. And normally, if there is nothing on the other lobe, if they had hemithyroidectomy, that would be the end of the story usually. But in the past, actually, many of those patients did receive radioactive iodine and all kind of aggressive treatment unnecessarily. So now we say for those tumors that already resected for whatever reason, and they are less than 1 centimeter, there is no reason to complete the surgery with complete thyroidectomy, although you do ultrasound of the other lobe. And also there is no place for radioactive iodine therapy. Yes, please.
Is it routine to do CT neck and chest in follow-up of the thyroid cases?
The answer is no. So the newer guidelines that is coming very soon, they're working on it, but many of us know that guidelines because they're talked about a lot. They will tell us CT scan should be done preoperatively on patients who might have extensive lymph node or the tumor is so large that you suspect structure. So it is to lead the surgeon for the best surgery. Basically, this is the reason. Post-operatively, do we do CT, neck, or even chest routine? No, we don't. We depend on ultrasound. Only if you think there is a disease that you cannot find on ultrasound, TG elevated, and you don't know where's the disease. So we do, in that case, we do CT, neck, and chest to investigate.
Another question, please, regarding sperm bank in male patient, especially adult patient or still not married patient or didn't complete the family. Is there a rule in those patients to do semen bank or sperm bank?
Oh, okay, for radioactive iodine. So we normally don't do this because the decrease in sperm count apparently is transient in those patients. And we prefer that they don't have pregnancy or impregnate their wives during the first 6 months after radio, because we don't know what's the effect. If somebody is already borderline low sperm, it might make sense because there might be some decrease in the sperm count.
The last question regarding radioactive iodine and impaired kidney. Is there any modification of those?
Yeah, so kidney patients, especially those on dialysis, there is no side effect from the radioactive iodine except that they take long time to clear, so to decrease their radiation. And we have special arrangement where they're dialyzed like 2-3 days after the radioactive iodine.
If impaired kidney without dialysis?
Impaired kidney without dialysis, they're fine. They usually reduce the dose a little bit. I think Dr. Tooley might do it on this. So any modification of those for renal not on dialysis?
Yep, we just reduce the dose, taking consideration that the iodine residence time in the patient will be longer because excretion is impaired. So we reduce the dose accordingly. We adjust that. And on the dialysis patient, because these patients will be taken care by, and they will go home immediately, and there'll be other people taking care of them. So we normally give the dose that we'll give to people that we are giving them as outpatient treatment. And the regulation we follow here is less than 30 millikilodose.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. It's my pleasure to be here today and share with you some new data on the role of TKIs in differentiated thyroid cancer. First of all, I'd like to thank Dr. Rauf Hussein, who gave us a comprehensive presentation on the patient's journey from diagnosis to treatment. We all know that those patients, they live long. They have a median survival around 10 years, and 90% of the papillary thyroid cancer, 98%, they will live 10 years. However, around 10 to 15% of the patients, they will become radioactive iodine refractory. And then a few years back, we don't have many options for this, but currently we do have treatment options for those patients. So my task today is to continue with the journey of those patients who became radioactive iodine refractory. Okay, so I'm gonna touch on a short introduction, signaling pathways in differentiated thyroid cancer, the FDA approved TKIs in radioactive iodine refractory, and then we'll try to sum up. So as we all know, the survival of radioactive iodine refractory differentiated thyroid cancer is really dismal, and the median survival is less than 3 years. So you are going to lose your patient if he becomes radioactive iodine. So when should we use systemic treatment? This is not compulsory indications. However, there are logical indications from multiple trials when you cannot manage the tumor burden with a local therapy, if the patient is symptomatic to prevent catastrophe or medical emergency, if the patient have progressed based on the RECIST criteria, progressive disease is defined as a more than 20% from the baseline of the target lesions, or appearance of new lesions mainly. Currently, we can use PET scan for this. However, we don't treat those patients based on the radiographs only or the thyroglobulin level. So Until 2011, no therapeutic options were available for those patients with radioactive refractory disease. Conventional therapies like radiation therapy, chemotherapy were used as a palliative kind of treatment. As you all know, we have seldom data for the chemotherapy. Combination adriamycin cisplatin compared to adriamycin with no marvelous result. And the median time to progression is around 3 months, and the median overall survival is around 8 months. So chemotherapy doesn't help our patients much. So in my opinion, the role of chemotherapy in radioactive iodine is obsolete unless if you cannot give the patient, your patient TKI with the current new data. Several studies have identified the cause of radioactive iodine refractoriness, and this can be grouped mainly in these three genetic mutations. RET and PTC rearrangement comes on top of this in papillary thyroid cancer. We have RAS and BRAF mutations, the second kind of mutation, and the beta-catenin. And this was linked to the radioactive iodine uptake refractoriness. So with identifying this kind of mutations, this led to the advent of new class of medications labeled or named tyrosine kinase inhibitor. When you block these kind of mutations, then you can treat your patients. So we have seen these cartoons demonstrating the survival pathways involved in the development of thyroid cancer. We have seen this in multiple malignancies. You can see here the MAP kinase pathway, which is the RAS-RAF-MEK pathway, and the PIK3 kinase and mTOR pathway. Once these pathways are activated, the phosphorylated ERK and the phosphorylated S6K, they go into the nucleus, they start stimulating the cells to proliferate, start the survival, proliferation, and the migration, in addition to production of HIF-alpha, which results in angiogenesis pathway. And this gives us a hint why the new medications will work in this kind of disease. And in the blue blocks here, you can see multiple tyrosine kinases which are involved in treating this or blocking this kind of mutations. And this slide shows you a summary of most of the genetic mutations which were identified in the pathogenesis. You can see here papillary, 50% they do have BRAF mutation. And in the follicular, the RAS mutation, 50%. And we can group the papillary, follicular, and the polydifferentiated carcinoma in group as a differentiated thyroid cancer. This slide shows you the spectrum of multiple agents that can be used in treatment of radioactive iodine differentiated thyroid cancer. On top of multikinase angiogenesis, on top of them is the sorafenib. We know sorafenib is active in other cancers like the hepatocellular carcinoma, of course, and the renal cell carcinoma. And we do have some selective BRAF inhibitors like the BRAF and the mTOR inhibitors, the temsirolimus, and the new agents, the MEK inhibitors, selumetinib. Even selumetinib now is tested in a trial trying to revert the radioactive iodine refractoriness. So let's see what do we have from kind of data supporting these agents. And this table summarizes the spectrum of activity of tyrosine kinases. So we can see here that sorafenib is a VEGFR inhibitor, BRAF inhibitor, platelet-derived growth factor inhibitor, KIT and RET. So it's a multi-kinase inhibitor, actually. And I'm here highlighting the lenvatinib as well because we had a positive data, and this is what I'm going to discuss in a minute. Sorafenib has been tested in a phase 3 placebo-controlled randomized trial against placebo in this kind of patients. As I mentioned, it is active agent in hepatocellular and renal, and has been tested in a phase 1 and phase 2 in this subset of patients and has a proven efficacy. So around 400 patients, they were randomized with 1-to-1 randomization. The one thing that I want to allude here, that the progression was defined according to the investigator. So they didn't send the patient for independent radiology review. And the primary endpoint was progression-free survival. Here, this table shows you how did they define the radioactive iodine refractoriness. Patients had to be progressed within the past 16 months from the last dose of radioactive iodine and continued and received the maximum dose of radioactive iodine. So the only thing here that I want to mention is the investigator-dependent assessment. So the patients were equally balanced in both arms, and the most important clinical thing here, that most of the patients, 95%, they had performance stats of 0 to 1. So don't try this agent in a patient with a performance stats of 3. Okay, the other issue that 2/3 of the patient, they had a papillary thyroid cancer. Most of the patient, they were distant metastasis, and the median cumulative radioactive iodine activity was around 400 millicurie. So, and here is the most important slide for this thing. Sorafenib was able to double the progression-free survival. So it was a positive study from the clinical point of view and from the statistical point of view, with a hazard ratio of 0.58. So you can see the curve. Okay, in a subset analysis, most of the subgroups, or even all the subgroups of the patients, they benefited from receiving sorafenib. However, there was no overall survival benefit, and this is because 70% of the patients, they crossed over from placebo to sorafenib arm post-progression. Few things and few numbers I want to remember here. 12% was the response rate with sorafenib, and the median duration of response was 10 months. Again, 12% and 10 months. Okay, what about the toxicity? Was it tolerable medication or not? Let us see. The dose reduction was seen in around 64%, dose interruption, 2/3 of the patient, and 18% of the patient did not tolerate to continue treatment. Okay, so remember again these numbers. And of course, those who treated patients with renal cell and hepatocellular carcinoma, they know the toxicity profile of these patients, they are not benign medications. So of course, grade 3 and 4 toxicity, 20% of the patients, so 1 out of 5 patients developed hand and foot syndrome. Remember this, 5.8 fatigue and hypertension, almost 10%. We are talking about grade 3 and 4. Further update of this data, they wanted to see if BRAF has any prognostic or predictive value for those, and unfortunately it lost its power. So whether the patient is BRAF wild or BRAF mutant, they both benefited from sorafenib. So it's not a compulsory to do BRAF testing before giving sorafenib. Other updating data, Schlumberger from France, from Institut Gustave Roussy, he did post hoc analysis. He tested the value of sorafenib in patients with a large tumor volume with an average of more than 1.5 centimeter versus tumors with less than 1.5 centimeter. And the benefit was seen more in patients with a larger tumor size, more than 1.5 centimeter. So if you have patients with a larger tumor volume, definitely they will benefit more from sorafenib. And that was the conclusion. Sorafenib, of course, was the first agent to show progression-free survival advantage versus placebo, and it was given and granted the FDA approval. So what about, it's not the only player in the field. Actually, lenvatinib is another selective tyrosine kinase inhibitor, which is a more selective, rapid onset of action and slower dissociation from the receptor. As you can see here, the differences here, the colored balloons here, shows you the site of action of each medication. Lenvatinib only works in the tyrosine kinase kind of receptor. However, sorafenib has multiple sites of action. And of course, we can expect some more side effects with the sorafenib compared to lenvatinib before starting and talking about the efficacy data. So knowledge of kinase selectivity of tyrosine kinase provides a better understanding of the activity and the mechanism of side effects. So again, lenvatinib was tested against placebo in a phase 3 study. In a 2-to-1 randomization, lenvatinib is a product from Ayazi. It was given at a dose of 24 milligram PO daily. The only difference here in this study compared to the other one is that patients were included based on an independent radiology reviewers. So not every patient allowed to be included in the study unless they have a confirmed kind of progression, and the last dose of radioactive iodine was prior 13 months before inclusion in the study. The other most important difference is that first-line VEGF or VEGFR target therapy was allowed to be included in this study. So it was tested at a first-line and a second-line setting. And here is a list of the definition of radioactive iodine refractoriness. And the primary endpoint was again progression-free survival. Just to show you a hint on the clinical data of the patients included in the study, most of the patients, again, 95% 0 to 1. Okay, so don't give this kind of medication for a patient sitting in bed most of the time and say that we do have an active medication. As I told you, 3/4 of the patients, that was first line, and 25% of the patient had a VEGFR kind of treatment. Around 50% of the patient, they were papillary, and 1/3 it was follicular. 70% of the patient received the prior radioactive iodine within the 12 months of inclusion. And here is a list of the previous VEGFR inhibitors given for the patients. So most of the patients previously received sorafenib as a first-line treatment. So, and here is the most important thing, progression-free survival. Needless to say that, okay, we can see more efficacy of lenvatinib versus placebo compared to sorafenib, 18 months. Remember, there was 10 months versus 3.6, and the hazard ratio was 0.2. And here, I don't like the cross-trial comparison, however, but just to show you that, okay, we have a more active agent, which is the lenvatinib. Objective response rate, and this was surprising to all of us because, you know, tyrosine kinase, they are usually cytostatic kind of agents, so we don't expect much as a response rate. However, here it was around 65% compared to 12 in the other trial. Though 63% of the responses were partial responses. The initial intention to treat survival data, there was no statistical significant difference, and of course this is because of the crossover from the placebo to lenvatinib. They broke down the data according to the histological subtype, both papillary and follicular. They benefited from lenvatinib, and those who received VEGFR targeted therapy or no prior VEGF both benefited from lenvatinib. So you can give lenvatinib post sorafenib. So this is the message from this study. However, let's see the bad side of the medication. Okay, again, grade 3 or more, 42% hypertension. So maybe it's not advisable to be given for patients with uncontrolled hypertension because it will get worse, of course. 3% nausea and vomiting, and 3% hand and foot syndrome. Compared to sorafenib, it's a little bit annoying for the patients. Okay, let us see. Dose reduction, 67%, comparable to sorafenib. Dose interruption, 82%, more than sorafenib, so it's less tolerable maybe. And discontinuation of treatment, 14% compared to 18%. And the bad thing is that we noticed some fatal death is related to the medication. 6 patients, 1 patient died because of pulmonary embolism, 1 patient because of hemorrhagic stroke, and 4 patients general deterioration of health. This is very important to show you. This is the progression-free survival curve for those who shifted to sorafenib, to lenvatinib post-progression, and with a progression-free survival of 12 months. So if you start late, you will lose 6 months from the progression-free survival. Okay, the median duration of treatment 13 months, and the median time to first dose reduction 3 months. So don't expect that you will require dose reduction early. So the conclusion that it was an active medication improved the progression-free survival up to 18 months. Overall responses 65%, mostly partial responses, and they reported that there were no unexpected safety concern. Adverse events were largely managed by dose modification or clinical interventions. So 3 weeks ago, in the last ESMO ECHO meeting, there was a survival data on lenvatinib. So actually they created a statistical model called rank preservative structure failure time to compensate for the crossover from placebo to lenvatinib arm, and they reported that there was a statistical survival difference favoring lenvatinib, and the survival is not yet reached versus 19 for the placebo arm. Accordingly, I think TKI has changed, and I hope that I was able to convince you that new TKIs have changed the paradigm of management of radioactive iodine differentiated thyroid cancer. And of course, the NCCN guidelines, as oncologists, you know, these guidelines has been modified, and they added TKIs for those who are radioactive iodine with a metastatic or unresectable disease. So in conclusion, sorafenib and lenvatinib, now they are the only two FDA-approved TKIs for radioactive iodine, the differentiated thyroid, refractory differentiated thyroid cancer. TKIs are not benign medications, and the side effects should be monitored with vigilance. This is very important. Remember that we are going to give this medication for relatively asymptomatic and a good performance, and you are going to annoy them. So 20% they will have a hand-foot syndrome, they will have hypertension, they will have fatigue. So the key question, when to start your treatment, because once you start, you are stuck. Okay, importantly, long-term side effects of TKI remain largely unknown, especially for differentiated thyroid cancer patients who may live long even after stopping of the medication or even as a radioactive iodine refractory. So we don't have much data. The only data comes from the renal cell carcinoma on long term. But from our experience, the patients who tolerate TKIs, they will tolerate for longer time. The optimal treatment strategy, including when to start TKIs, is still unclear. I think the endocrinologists have a major task to properly identify the clear definition for radioactive iodine refractoriness. There should be a uniform guidelines for that, and further research is necessary to provide more personalized approach for each patient. Multidisciplinarity is very important, critical for deciding further management for this patient in order to achieve your goal with a maximum efficacy and less toxicity. And thank you very much for your attention. Questions? Yes?
For those patients without progression of disease and without major side effects, for how long do you use the TKIs?
Till progression or unacceptable toxicity. This was the definition.
My question for those who have nothing from this.
Nothing what?
Either progression or side effects.
You continue. You continue. Yes. That was the definition according to the clinical trials. You get your evidence according to the clinical trial definition. This benefit was seen until progression or development of unacceptable toxicity.
For the group of patients who started on lenvatinib, then shifted to sorafenib, how long? Who started on lenvatinib and then shifted to sorafenib?
No, they didn't report this data. They actually, sorafenib and shifted to lenvatinib.
But were allowed on first line and second line.
Yes.
There is no data about those who started lenvatinib and...
No, we don't have this kind of data. We have sorafenib shifted to lenvatinib, progression-free survival 12 months. So less compared to the intention to treat population, 18 months.
Yes, so maybe still an answer for this question, because already the patient who progressed on lenvatinib, they will receive sorafenib at the second line based on the trial, but
we don't have this kind of data.
Thank you.
This publication was published in the New England Journal of Medicine, the lenvatinib data, and the sorafenib is also available. So for more details or those who are interested. Questions?
I can comment. Thank you very much. It's a very nice presentation. And indeed, it's the difficulty to identify the patient that may be candidate or not, because as Hussein has alluded, and we know this from practice, that not all the refractory patients are the same. They're a very heterogeneous group of patients. But you have refractory who can be stable for years and years, even with bone mets, lung mets, and those are not candidates for TKI. So progression is important, and also the burden of the disease. So you don't want to treat very small amount of tumor, 2 or 3 small lesions in the lung that are not close to, let's say, central area, which can be threatening if they are enlarging. So these are 2 conditions, and the difficulty also because of the quality of life, age of patient. So the decision is not really easy, and I think the patient, the family should be also involved in the decision. But because we were part of the decision trial at King Faisal, we had 5 patients, and till now in the extended phase, because of their response or stability or minimal progression, I have 3 patients now for more than 4 years on sorafenib. One of them is still stable, 2 of them showing minimal progression, which now we decided to continue their treatment in spite of this, because the alternative is to stop and change them to very rapid progression, which sometimes can happen after stopping the medication.
I have a question, please.
Yes, please, go ahead.
For those who responded for anti-TKIs, can we use again radioactive iodine?
No, by definition, they should be refractory to radioactive iodine.
If they responded to TKIs,
Yeah, but they don't become usually sensitive to radioactive iodine. I think you need to ask this question before you start the treatment with TKI, because those patients who might still benefit from radioactive iodine, still it is a therapy preferred with less side effects. If they have no benefit whatsoever, or they are not taking iodine at all, then usually you go and you don't give radioactive iodine again. However, saying this in the future, things might change, because now they're talking about medication that can sensitize the tumors again.
Yeah.
I think this should be still in the stage before TKI. And I think in the next few years, we're gonna see this issue readdressed, where some of the patients that we decide that they are refractory, they're really not refractory, but they have problem with the turnover of the iodine, or they have problem with because of the sodium iodine receptor, and that they can become sensitive by certain type of treatment or procedure. Then they should probably go through this before they go for TKI.
Yes, as Dr. Rauf Hussain mentioned, yes, there is an ongoing trial, as I mentioned, selumetinib MEK inhibitor for radioactive iodine before proceeding for this, aiming at resuming the activity of radioactive iodine.
May I have a question,
Yeah,
please?
please.
Would you go for a for completely asymptomatic patient of radioactive iodine refractory to go for treatment for TKI, or
This
would
is
you
the-
like to wait until they become asymptomatic, even will not deteriorate it as regard the echo performance? So I will keep the patient for let's say that the performance 0 to 1 and it's totally asymptomatic. I'll wait for him to be symptomatic but not deteriorated as regard the echo to start this treatment.
Okay.
Which scenario would you like to
Would you like to
prefer
answer
for
this, or we wait for the
So
clinical?
I'm thinking that you have a progressive patient. So the
We have a
patient has progressive disease,
radioiodine
but completely
refractory,
asymptomatic.
but asymptomatic. Totally
It
asymptomatic.
depends where are these lesions, and what's the burden of the tumor, because a lot of the patients do not have symptoms actually. And they tell you they might be symptomatic, but don't wait till they have too much symptoms, like the second patient you'll see, because once they have severe symptoms, they're not going to benefit from the treatment. So yes, if the lesions are close to an airway or close to the pleura, or can cause compression, we will probably treat them even if they are not symptomatic. Otherwise, if the burden of disease is not very high and they're not symptomatic and the progression is there but not very convincing, they have no symptoms, then I think you need to kind of balance things. Depends on their age, depends on their quality of life. I don't think there's a straightforward answer for this. Okay, let's go ahead with our cases. We have 20 minutes for each case, so we can make it for the lunch. The case one, I think it illustrates the importance of multimodal therapy. And fortunately, again, for most of our patients, we don't need to do other than surgery, radioactive iodine. But there are a good number of patients, at least in our center, that we see where other type of treatments has to also come to help. So in this case, we have a very young female, 21-year-old, presenting with a femur fracture and femur lesion. She had an FNA that confirmed metastatic follicular thyroid cancer. So she was referred from orthopedic, because this is how she presented. And they went ahead and did debulking and prosthesis insertion after they did a tumor embolization, because there was a big soft tissue tumor, to shrink the tumor a little bit, the orthopedic did this procedure, and the pathology confirmed that she had metastatic follicular thyroid cancer. So they did their part, and they sent the patient to endocrinology to handle. This is actually the X-ray. Dr. Tooley was kind enough to put his slide with me, so I'm gonna give him the floor in a minute, but maybe this is easy for an endocrinologist to tell you this is a fracture. And this is a bone scan showing an uptake here. Is there any other uptake, Mahmoud?
Yes, you have
Okay.
it, the lumbar spine L2,
Yeah.
and also, and the lower.
Maybe a rib?
And then
Is there a rib here? Or?
T10, not
Yeah.
very much.
Yeah.
When you see the images at T10, also there's metastasis. So T10, L1, L2, and the 10th rib
Plus,
on the
of
left.
course, this.
And this is gross pathological
big mass.
fracture,
Yeah.
of course, on
All right.
that's okay.
So this is where we got the patient. She already had her orthopedic thing. And the question we have, what would be the next step? What should we do from here on? Any idea? I'm going to have you, interact with us as much as possible. Yeah.
So I think we will complete the staging workup, CT scan, if we to know what
Okay.
we have a baseline.
Okay.
And still we need to go for surgery to remove
Okay.
the thyroid so
Yeah,
we can get
very
better
good.
chance.
That's exactly, I want to hear this, because our patients who come with metastasis, they still we go for thyroidectomy. So thyroid cancer is a little different from other cancers, where sometimes you might decide not to resect the primary tumor because there's no point. Here, there's always a point, because if we give radioactive iodine, we have to have the primary tumor out. Otherwise, there will be no benefit. The thyroid will take all the iodine, and the Mets will not get anything. So, of course, an ultrasound of the thyroid, I think this is the easiest thing. But before that, we palpate the gland. And in this patient, there was a nodule. And you can see this big nodule on the ultrasound. Any features, Mahmoud, here that might...
Well, this is grossly pathological. It's a solid tumor.
Yeah.
It was good as a tumor.
It's not very, impressive from ultrasound features that it's a cancer or not a cancer, right?
Yeah. Actually, Dr. Zubair.
Any radiologist?
Yeah, Dr. Zubair.
Here, you see a very well-defined nodule. You almost see a halo around. What I would really like to know is, I would like to see a Doppler color picture, because I would like to see internal vascularity here.
Yeah.
Normally, you would have type 2 vascularity around a benign nodule, which is pericapsular vascularity.
Yes.
But if there is vascularity within it, that would be the strongest feature.
In Doppler, there was vascularity in it.
It was
It's a-
vascular.
It was vascular, so yeah.
So again, all these features are just a hint, and it doesn't tell us
still
much.
unique.
So we do the FNA. The FNA, of course, was suggestive, but for sure this patient had thyroid cancer because it came from the thyroid. So the patient underwent total thyroidectomy and left neck dissection, and the pathology showed very large tumor, 9.5 centimeter. This is how large, tumors, sometimes they come to us, and I don't know why patients wait that long. It was PTC follicular variant and vascular invasion was there on the pathology. So normally after that we, for a normal patient, we'll do an ultrasound post-op. Again, this is not an indication, but if the surgery was done outside, we do it to see if there's any residual. But a scan, a whole body scan, would be nice to do at this stage. Mahmoud, you want to comment on this?
This is actually a PET scan.
A PET scan?
Yes.
Oh, why did you do PET scan?
I think at this stage,
So normally we do iodine scan.
I guess
But
by
in
this time we had the histology, but
Yeah,
before it was not known what was cause of this pathological fracture. So I think FDG PET was considered. By then, after the histology came back, and this was known as a differentiated thyroid carcinoma, then the next slide you see that we had a whole body scan.
Okay.
If you go to
So
the next
what
slide.
do you see on the PET?
Here, just increased uptake in the fracture side, and this is FDG will go there because of the tumor as well as the fracture. Otherwise, this tumor takes less FDG compared to the iodine scan. As if you put the two together, the next slide, because I want to comment.
I think I've changed your slide.
You changed the slide? Because I wanted to comment here.
It comes later.
It comes later. When we did the whole body scan, then the tumor obviously was taking much more iodine, and you have all the sites of metastasis more visible than the FDG. Now, this is very important in the context of what we are talking, that normally we don't do PET scan in this patient. Normally we do whole body scan, iodine scan as a starting point. And if the tumor takes up iodine, we go ahead and treat the patient with radioactive iodine. Now, this is assuming then we are talking these difficult patients that in the end there will be a case that will go refractory, for example. If the patient is taking up, the tumor is taking up iodine from the start, and then later on the patient become refractory, and this is assuming that the tumor has changes, it becomes de-differentiated. In that case, the tumor will change from being iodine positive to being PET positive when it is becoming differentiated, undifferentiated towards the end. And these type of patients, if they become refractory, will be the ones which are very important in future to be the ones that probably will be stimulated by the new approach of stimulation, because they are tumors which started first as being iodine positive, then they become iodine negative, what we call whole body scan negative with TG, with high TG. If we stimulate this patient, then they will become again iodine positive, and then we can treat again. And this is the approach of the future. On the other hand, you may have other patients who from the start, if you do PET and you do iodine scan from day one, they will have heterogeneity, which means there are some tumors which take iodine and some tumors which take FDG, and they are not congruent. Now, in this patient, if you treat them with radioactive iodine, which we do now, because we normally don't do PET on them, so we don't know they have this thing. If we treat them with radioactive, then we are selecting out. We will select out the tumors which respond to iodine, and those tumors which from the start were there, but they were not iodine positive, they were PET positive, now will show up when we do PET. So this category will not benefit from stimulation. The stimulation in future, we are talking about stimulation. This patient will not benefit from stimulation. Probably these patients are the ones, if we can choose them from the start, they're the ones who should start with TPK from the start.
Thank you.
If you understand this concept. I went into detail so that it'll be simple. When
you're rushing a little bit. You're ahead of me now.
Okay.
But that's fine.
Okay.
So I think the message here is PET scan to us is positive PET is a bad prognostic feature in thyroid cancer. The well-differentiated thyroid cancer mostly are PET negative.
Yeah.
And so we don't want to give you the impression that we should do PET. The whole body scan is the way to go, but PET can be done if we think it's a more aggressive tumor or we cannot find the uptake on the scan. In this specific patient, when we did the whole body scan, there was uptake in the spine, so there was some question whether she has metastasis in the spine. So it makes sense before we proceed for a full treatment is to investigate whether there's any threatening lesion in this patient.
Yeah.
And again, Dr. Tully will help us understanding this is an MRI of the spine that was done. What do we see here?
I'll let Dr. Zubair read this one. He's a radiologist.
Right. So,
Okay.
hi. You've got three sagittal views, and all of them seem to be T2 weighted, and they're fat suppressed. And what you see is an obvious mass, which is showing you edema, and it is involving the vertebra, but there is a large component within the spinal canal itself, and that's probably the main concern here.
Yeah, exactly.
The only lesion I can see on these views.
So, of course, one could argue that this could have been even done before the surgery for this patient, before she had thyroidectomy. But the thyroidectomy was done already, and apparently she did not have neurological symptoms at that point. But at this time, I think the concern is that something could happen. So this is an emergency situation that need to be addressed. So indeed, this patient, we had to discuss what to do. Our neurosurgeon and orthopedic helped. They decided to do tumor embolization, and then she went to decompression for relief of nerve root and Kodak-Wine. That was at the L2 level. XRT was initiated right after this with 10 sessions. This is all before even we gave any radioactive iodine. Because giving radioactive iodine to somebody like this would put him under even more risk of compression before we take. This is the importance, I think, of local directed therapy that's now being emphasized in patients with thyroid cancer. So this is how the patient looked after surgery. Now I-131. We go back to the I-131, and in this patient, she had, hopefully I have the scan for you. Is this the one?
Yeah. That's
Okay.
correct.
Okay, you want to explain it to us then?
Yeah, this is and we do this as Dr. Hussein said, some centers don't do this, the diagnostic scan before doing the treatment. And for our center, we believe this is important because we receive patients from many centers. So we need to evaluate the situation of the patient before we give the iodine. For example, this is a good case to point to the importance of doing this. You see this uptake in L2. You see multiple metastases. And very important, this L2. If you didn't know this and you go ahead and give the treatment, then you are going to jeopardize the patient, going to cause edema and then cause complication. So knowing this beforehand is very important so that we take the precautions of giving the patients preparation before we give the treatment. So in general, we do this scan, and this will be followed by the radioactive iodine. You see multiple areas of metastasis that you can see in the ribs and in
And the neck, up,
the neck,
residual.
that's the residual.
Yeah, yeah.
And then there is uptake in L. We talked about the L1 and the lumbar. And also the site of the fracture is now showing just diffuse mild uptake in the site of fracture.
There are always things that only radiologists can see, so I don't see anything here.
Okay.
Okay.
And then we give the treatment doses.
So you see that the patient received the first dose was, of course, high dose because of the bone metastasis, 191 millicurie in March 2012. Because of persistent uptake, she went to receive a second and a third dose, obviously once a year almost, with a total dose of now reaching almost 600 millicurie. Now, some people do it even quicker. They might do it every 6 months instead of every once a year. And of course, in between, we have to assess the response to therapy. So after these 3 therapies, where the total now is 600 almost, her TG came down from 338 to 116. This is stimulated TG, and antibody is negative. So here, I think that because of the stability of the disease, the physicians kind of slow down on the treatment because the treatment was not curable. We do see curable pulmonary mets in this young age group. Bone mets are a little more difficult to eradicate, but it does happen in the teenager and the 20 people in their 20s where we can get complete remission. Not in this patient, which apparently has a worse disease than usual. So here she had another scan to reassess whether further doses should be given. Her TG is stable at this stage. And this is, I think, her scan, Mahmoud. This is the latest scan she had.
If you now, of course, if you remember the previous one, there's definitely mild progression, mild regression of those, if you judge on the intensity of uptake on most of the lesions. So this was regarding malnutrition.
And she still have, I'm sorry.
And then you have that, on the MRI, you have that lesion at L2 still demonstrated there before, yeah.
Okay. So I think at this stage, one could wonder whether we should stop and watch or should we give another dose. I don't think there's anything wrong here. And the decision was to give her, I think, a 4th dose.
Yeah.
She got another 200, so now we're reaching 800. The 600 is a kind of a number where we start to get worried. This is where leukemias start to get higher after dose of 600, but that doesn't mean it's the limit. There are patients who receive more than 1,000. In this patient, they decided because of her age to give another dose, and because there's some indication that she was responding. Although I would say it's not a complete response.
Can I comment to that?
Yes. Yeah.
As to how you decide to continue treatment when you reach these high doses, ideally one should do dosimetry, ideally. And you are planning not to give the bone marrow 2 grays of radiation. That's your reference point. So the limiting organ is the bone marrow. So the bone marrow should not receive 2 grays of radiation. Now doing dosimetry is not a routine thing, and not many centers do it. We don't even do it. So when you don't have dosimetry, what do? You judge it by the usual CBC findings. So your platelet, white cells, as long as those are normal, then you are okay to continue. Yeah. Especially the trend, repeated studies of white cell, platelets, you follow those, and they should be within normal limits. Then probably you're okay to continue. Definitely when you come beyond 800 to 1,000 millicuries, then dosimetry probably is a must now too.
I think there were some slide Dr. Tully has put, but maybe we'll skip some
These
of
you
them.
can skip them.
Yeah. So maybe we'll end on this one because I don't know. I want to hear your comments. If there's any comment on the management, I think the value of I-131 is established in this case, where it gives us a little bit of improvement and stability. In young patients, sometimes it can give full remission. Any possibility for cure in this patient? Doesn't look like, right? She doesn't seem to respond enough. Hopefully, newer therapy that make her tumor more sensitive to radioactive iodine.
Exactly. This
would maybe put her in remission.
Yeah. This is the future.
Yeah.
Probably this would be the type of patient that you would stimulate her. So
And
that
then
the iodine
I'm going to ask you and ask Dr. Sen Soudi if there's any role for chemo or TKIs in this patient. But let's hear your comments on the management. I'll just take one or two before we go to.
Can I just say, I know that the baseline PET was done, and that was negative except for where the fracture was, and the
Right.
uptake was
That's
probably
true.
due to fracture.
Yeah.
But because you did not have, although there was iodine uptake on consecutive scans,
Yeah.
was there any benefit in getting another PET to see whether there was any dedifferentiated disease?
Very, very good question, and especially if you're entertaining a treatment with TKI.
Getting into higher doses?
I agree, and that was not done. So you're absolutely right.
And the reason we have not done it, because I think up to now in King Faisal, the indication of doing PET is when the whole body scan is negative. With rising TG levels, then we do PET. So this patient, because doesn't fit that category.
But if you're embarking on TKI,
But
I
if
think
we
it's
embark on
highly
TKI,
recommended.
then we would,
It's highly recommended.
Please,
Okay.
regarding palliative radiotherapy in this patient, actually after decompression and stabilize her complaint, I think the palliative radiotherapy can be delayed after
The XRT. you mean?
after the radioactive iodine.
Yeah.
application.
I guess it
With
can.
decompression.
I guess it can. Yeah. Yeah. I don't know if there are any, thinking whether radioactive iodine should be first or XRT. I know that XRT can make radioactive iodine less effective. I don't know whether the opposite is true for a period of time. And then the cells become less refractory, but you might stun the cells so they don't take iodine.
If she has localized, I think if she has localized pain or something related to the
Decompression and fixation.
yeah, but maybe after, I don't know.
Right,
So
right.
she's
So
at this stage.
What-
I
what
don't
do you
think
think?
she's no. I don't think
Yeah.
she's candidate for any chemo or any TKI at this stage.
So she's not progressing, and the disease still kind of sensitive, although not completely refractory to radioactive iodine. Okay, I think I will skip to the second case. The case here indicate more the refractory cases of thyroid cancer. This is a patient who's 52-year-old. Known to have cancer or thyroid cancer diagnosed in 2008. He had total thyroidectomy with lymph node dissection. At that time, his pathology was showing 3 centimeter and 1.5. So it's a multifocal with the 3 centimeter lesion and another 1.3 centimeter lesion on the right and 0.4 centimeter lesion on the left. 3 lesions, and they were positive lymph nodes. Although this looks a little, maybe put him at the moderate risk group, that's not unusual, and a lot of those patients actually get cured after surgery and radioactive iodine and become low risk and complete remission. This is not the story in this patient. A whole body scan following the surgery, which is a routine, of course, showed small residual in the neck, which is not unusual, but maybe the first kind of hint for us that there's something wrong, or maybe we're dealing with more aggressive disease, is the TG being quite high even after surgery. That's not enough to alarm us, but it's something to draw the attention. So this is his whole body scan that was done after surgery and showed only uptake in the neck region, not unusual. He went ahead and received 153 millicurie because of the lymph node involvement in February of 2009. So far, everything looks like routine. Instead of improving, in March 2010, his TG went up to 174. Ultrasound showed a small mandibular lesion, looks like lymph node, and FNA proved that it was actually metastatic PTC, so he was sent again to surgery. It's not unusual that our patients go for first and second and sometimes 4 and 5 surgeries before they're completely cleaned. He was referred to surgery, and the surgery with removal of these lymph nodes indicated that's not only lymph node, but there was soft tissue invasion, this time like macroscopic invasion of the muscle and bilateral lymph node mets. So here is your second hint that you're dealing now with more aggressive disease than usual. Why those patients, or this patient is behaving more aggressive, we don't know. Is it related to BRAF mutation or other mutation? At that time, of course, we did not do much investigations, but they were not even available to us at that time. So what's the next step? He had a second surgery. Normally we reinvestigate if he has uptake with radioactive iodine to give a second dose, and this is what happened. So we did another whole body scan, and you see now the TG is reaching 600. So there is something wrong, there is some disease, and what do you say about the scan, Mahmoud?
Yeah, probably still very tiny uptake in the same focus. One could easily pass this as a negative whole body scan with positive TG. Just persistent. That tiny uptake does not explain the TG level. The TG level is definitely way, way out of this tiny minimal uptake in the neck. So there is something
we
going
can
on.
say this is scan negative,
Negative,
TG positive,
yes,
at least for an
positive
endocrinologist, I consider
Yes.
this
Yes, it's
scan
we can.
negative. And I think here depends, if you have a TG of 10, 20, you don't need to get so excited because sometimes the TG comes down with time. But TG 600, this is where you do anatomical imagings. You want to see the chest, the mediastinum, and whether there's a disease. And most of the time there's a disease either in the neck or in the chest. So first, of course, that whole body scan, actually, the physician who's treating him decided to give him a second dose of radioactive iodine. That sometimes we do for even scan negative as an empirical therapy, because about 30-40% of the cases might have uptake post-treatment because of the high dose. The value of this procedure now actually is being kind of questioned. It used to be very common that people do this. And now we question the value of giving these empirical therapy, because most of the time you're treating the physician, not the patient. But nevertheless, this happened, and I think Dr. Tully today had told me about a paper that he reviewed where there is occasionally some benefit from those. You want to comment on this?
Yeah, this is an old paper. I don't know the numbers. It's a meta-analysis actually of this procedure, which used to be very common. That people will do this empirical treatment on patients with whole body scan negative with positive TG and evaluate the post-therapy scan. And the post-therapy scan was positive in a big range, starts from 0 to 90%. And what is more important is what happened to the TG values, what the response of TG is. And it shows that there's some benefit in some patients, that TG levels will go down after these empirical treatments. So that was how.
So in this case, of course, a PET scan would be also helpful, and the PET scan in this patient showed some positive findings, which is what? Mahmoud, can you comment on this?
Yeah, that's neck uptake. You can see the right cervical.
So it's only neck uptake? Is there anything in the lung here?
At this point, neck uptake.
Yeah. Only neck uptake on the CT. The TG is still too high to be explained by one lymph node. And this is this is post-treatment. Is there anything we can see here that we did not see in the pre-treatment?
No, and when this happens, it means then this patient should not get an additional dose of this empirical treatment. They only get single.
Can we say now this is a refractory patient?
This is a refractory patient. Yeah. Okay. This is a refractory patient.
I was told I have only 5 minutes to finish.
Okay.
We did those, and now we have persistent disease. But not only this patient started to progress, as I will show you. Maybe I will skip through this to the images. This is in 2014. So you can see there's a period of time from 2011 or 12 to 14 where nothing was done. Of course, there were images done, but in terms of treatment, we didn't have anything to offer this patient. As you know, even TKI was not something, we did it as a study, but not as something we offer clinically till it's been approved, I think, 2014. Yeah.
And now, of course, you have bilateral lymph node metastasis on top of that neck mass.
So this patient is progressing now. The lung disease is progressing. And not even, when I saw this patient first time at this time, actually he was admitted to the hospital because he came to me with the most unusual symptoms that I see in thyroid cancer. He was losing weight. He was extremely short of breath. And you'll see why now when you see the CT scan. He was sweaty. He looked like somebody who has TB or lymphoma. And I know he had extensive lung metastasis by then, and I had to admit him to be sure he doesn't have something else. All the workup was negative, so we were convinced that his symptoms are related. He was having low appetite, all kinds of symptoms that related to the aggressiveness of his tumor. This is his CT, and I'm sorry, before that. So this is his PET CT, again showing the multiple lung lesions. We had to make a decision at that time because this person was actually, his symptoms were kind of too advanced, but we thought we'll offer him sorafenib. So this was started at a dose of 400 milligram twice daily at this time after this evaluation. We had to, of course, see him on once-a-month basis to be sure. He did well. Some of the symptoms improved, but also he was having side effects of the drug, like the hand and foot symptoms. Almost all our patients develop hand and foot symptoms, although they do improve with time. In February of 2015, this CT was done. So this is 3 months after the treatment, almost, or 3.5 months. And there was no progression. There was actually some necrosis, as you see those rings in some of these lesions, which indicated to us that probably the patient is responding to therapy. There was stability and some necrosis, so we were happy. And we said, okay, let's put up with these symptoms. You're having at least some of the symptoms also improved. The one that related to the sweating and the weight loss stopped at that point. However, in June of this year, we had to repeat his PET CT because the symptoms recurred, and he was saying that I'm getting worse, actually. So what do you see here, Mahmoud? Worsening?
Progression.
Yeah. Clear progression. And in September, he developed pleural effusion, and he was extremely short of breath. So at that time, we knew that sorafenib wasn't working. We had to admit him. We drained this. We give him bleomycin, but he also developed some reaction to bleomycin, which was pretty bad, actually. Later on, the X-ray looked a little better, but still he was almost completely oxygen dependent. This is how his CT looked like in September, which is even more progression of the disease. So I'm going to ask Hussein to comment. What would you do at this point?
Yeah, at this point, what's his performance status? I think this is very critical.
His performance is back to where he was, which is limited. Of course, now he's oxygen dependent. So I would say 2 or maybe, yeah.
If he's PS2, maybe we can offer him lenvatinib based on the data. Yeah. So this is the best available option for this guy. Yeah. Or of course, if we have a clinical trial, this is a second option.
So of course, we don't have lenvatinib, but I did consult with Dr. Schlumberger, and he said you could switch, because of the data you showed us, we could switch from sorafenib to lenvatinib or one of the other drugs also that he believes it works. Now we're trying to do so, but in the same time, you know that anti-BRAF drug that you mentioned, vemurafenib. We thought, because there's one case in a New England Journal reported with almost complete resolution of tumor like this. We thought if he's a BRAF positive, we had one patient supply of this drug in our pharmacy that was not used. So we thought, okay, let's take the chance. So what we're doing now, we send this tissue for BRAF. If it's positive, we're going to start the Vemura. If not, we're going to have to start him on lenvatinib.
I think with a high response rate, lenvatinib would be fine. Because again, what we know from melanoma, vemurafenib is very effective medication with a response rate around 60% as well. So.
Okay. I think I'll stop here, but if you guys have any question before we go to lunch. There were a lot of things, Doctor. Prepared for you, but maybe for another.
No, that's one cave, that cave only, which everybody knows about it. Not the cave back, only this.
Yeah, okay.
Which I think all the audience have seen this cave. So it just proves that when tumors become FDG positive, they have poor prognosis. And when the tumors remain FDG negative, they are good prognosis. So these patients, you can see the tumor becoming FDG positive, then the prognosis goes down, as this curve shows from Sloan Kettering study.
Okay, so we'll have more discussion over the lunch, maybe? Okay. Thank you very much.